care. It also has the function to contribute to the education and training for those preparing or receiving the CL psychiatry report, and to fulfill an archival role so as to inform future assessment and treatment. Also, if there's a medical legal issue, it is also to satisfy the medical legal expectations of a specialist consultation. So how do we write CL notes? So we may.
Beba, sorry. Ah, just want to emphasize lang previously dun sa role natin as CL psychiatrist, no? Actually, sino nga yung client natin to be kung tayo yung yung CL psychiatrist?
The consultee po, Doc.
Oo, so you have so I don't know, you have to be reminded of that, no, na it's more of kaya it's very important for the CL notes na simple, complete, no? Kasi hindi parang pareho ng natin ng the normal or the regular psych history na medyo mahaba siya. It could be like concise, no, less na medical jargon. So it comes to psychiatry na point of view kasi nga kailangan nila na mas maintindihan yung notes natin, no. So you should be reminded, no, it's very important to take note na yung consultee, so sino yung nag-refer sa atin. Okay? And then sige, you may continue.
So comprehensible in this case is not just how we write, but it also pertains to how it is being understood by the consultee as well. So while we may write our CL notes like how we write our psychiatry history in the OPD, like in this kind of format, since it's also our role to have the consultee also understand in our perspective the linkages between the psychiatric and the medical issues, we may want to consider doing it in this kind of format. So in this format, first there is the general data of the patient, and it mentions why you referred the patient, why the consultant referred the patient to us at this particular time, our findings, and then who are the patient's family and other supports, how we understand these findings. So this is the link between the psychiatric and the medical, and how do we recommend regarding management and further developments and follow-up. So we'll be taking this up one by one. So who is the patient? So we may start with the referrer's name, the CL assessor's name, the date of referral, and the dates of consultation, which should be clearly cited at the beginning of the section, so at the side notes. So this is then followed by a portrait of the referred patient. So it typically covers the sex, the age, the ethnicity, religious affiliation, marital status, occupation, and pertinent life circumstances. And then it should be followed by a brief acknowledgement of any past psychiatric or medical illness, if it's appropriate, and followed by the statement of the current illness. So for an example, the patient's name is William Smith. The referrer, for example, is Dr. John Stevens from the coronary care unit. So you may write the name of the resident and the department, so internal medicine, for example. Then date referred and date first seen. Then the CL psychiatry, so resident, for example, Dr. Slaven, then consultant.
So yung first pa lang, no, that's very very important na yung date ng, kasi mostly nakakalimutan natin yun, no, yung date of admission. Actually, it should be reason for the admission ng patient, and then the day of the referral and why was the patient being referred, no? So para first line pa lang, parang meron ka ng background kung bakit siya ni-refer at medyo konti about the patient. So that's the first line is very important, no, sa CL notes.
So for example, we'll have the paragraph after the identifying data. For example, William Smith, a 59-year-old separated truck driver receiving sickness benefits, lived with his two sons in a regional town, currently being treated in the CCU for unstable angina and scheduled for angioplasty within a few days. So you can have that identifying data for the patient. Next would be why did they refer the patient? So at this part, we have to crystallize the questions posed by the referrer. They may refer for a brief or a cryptic referral. So for example, we have these weird referrals for kanang evaluation, but it's not clear kung saan ilahang ginapa-evaluate, or the assessor. So the assessor or may extrapolate from other sources, so we can get that from the nurses, the charts, so why they are really referring. So for example, the typical question would be, is the patient depressed? But actually, if you look into the other concerns, there may be the concern for suicidal risk, or the behavior of the patient may actually be jeopardizing nursing care or medical care, and which issues they can have direct bearing on management. So that's a difference between manifest versus latent request. So the manifest request would be the one that they state in the referral, whereas the latent would be upon assessment. This is actually what they are concerned of. So for example,
So, sorry, Nueva, no? So that's very important. That's why, di ba, sa process ng CL Psychiatry, yung first would be, kailangan mo makausap si consultee to parang i-clarify kung ano talaga yung reason for the referral, because sometimes, no, they would not know. Kasi for example, they would just generalize the patient having behavioral change, no, common yon, or the patient is very difficult, pero upon, kasi that's our role, no, to clarify and to assess the patient if ano talaga yung problem ng patient, and then we have to write in our notes, no, na kung ano para mas ma-understand nila yung patient. Okay, so that would be the role of the CL psychiatrist.
And at the end of that, we also have to go back to the question why they referred the patient. So this can be out of respect also to the consultee. So we may state it as, for example, in the example, Mr. Smith is tearful and expresses a wish to die, or to put it in his own words, it's too much, I can't go on. You have asked us to assess his mental state as an urgent matter prior to angioplasty. So we have to state their specific reason for evaluation. So next we go to the finding. So what did we find? So this portion can include relevant clinical features, including notable negative findings. So for example, if they ask for assessment for suicidal risk, so you can put that. We can also put in the verbatim comments of the patient or the watcher. So kanang mas truthful ang atong report. And any discrepancies should also be spelled out. For example, the nursing staff stated this and that, whereas the patient mentioned this. So also, if the patient was unaware of the consultation request, this should also be recorded along with his or her reaction. And as this may reflect also the dynamics of the referring unit that needs addressing. So in RCL, we really ask for the informed consent prior to assessment of the patient. Then psychiatric findings are juxtaposed alongside pertinent clinical data. So example, marked anxiety in the context of dramatic worsening of chronic obstructive airway disease. So you should always mind ang medical aspect po. So the medical conditions for which the patient is being treated are pivotal to the report. So again, we should be looking for the link of the psychiatric condition to the medical or surgical condition. So pwede na it can be as simple as psychiatric jud primary, like in cases of suicidal attempts like ingestion of substances. So murag mas direct ang link between psychiatric and medical. Pero sometimes mag-merge po ang medical condition and ang psychiatric condition. Then we should state the brief summary of the physical illness, the current symptoms, and past and current treatment. It should help us orient also all participating clinicians. So in this portion, we have to summarize the effects of the condition on the patient's life and their responses to the illness. So there are three facets here. The reaction might be, we have a cognitive component, an emotional, as well as a behavioral component. So for the cognitive facet, what does the illness mean to the patient and their understanding of its causes, prognosis, and treatment. Then we include their emotional reaction, like their fear, anger, guilt, shame, hopelessness, or other emotional reactions, and their behavioral reactions as well. So dependency, fatalism, non-cooperativeness, attention seeking, and aggressions. So we also have to state our mental status exam with emphasis on features that point to immediate risk assessment and to likely psychiatric diagnosis. So for example, in the examples previously, so Mr. Smith gives a 10-year history of multiple medical problems, including poor controlled angina, renal colic, and work-related foot injury. He had a history of alcohol abuse and has abstained for the past 5 years and has not been examined by the psychiatrist. So in this part, the psychiatrist already mentioned the medical problems of the patients and the psychiatric history, that he was not previously seen by the psychiatrist or no psychiatric illnesses prior. So in this part, the most recent episode of lowered mood began 6 months ago. So the psychiatrist records here the emotional reaction of the patient towards his illness. So when his angina and renal colic worsened markedly. So following angiography, he was advised that he did not require cardiac surgery but would need to lose weight and give up the only activities that give him pleasure. So the renal colic occurring daily with maximal oral analgesic and non-steroidal medications. So murag ginarate lang niya kung saan what the patient has gone through. Then the psychiatrist also recorded here the emotional reaction of being furious towards the doctor who advised him that he did not require surgery. And so also an inquiry about depressive and anxiety and psychotic features proved negative with no disturbance of sleep or other biological functions. So in here, the psychiatrist stated the murag nag-examine na siya of the DSM-5 criteria, and he stated that it's a negative. The probe turned out negative. But he stated it in a simpler way. Then on mental status, so this is the statement of the mental status examination. So this is the findings of the psychiatrist to assess. So of note, he mentioned here the insight of the patient towards his illness. So he did not see himself as emotionally ill and everything would be okay if his physical problems were properly treated. So that's one way of how we we juxtapose the medical and the psychiatric symptoms of the patient. Then it's also important.
Sorry. Another difference would be in CL notes writing. Before we go to the patient, diba, we had parang background na of the patient, no, rather than the primary na lahat yun iisa-isahin muna natin, no. So that would be the difference, no, na we have the background na. So we can directly parang give na parang based on the referral notes or based on the history. So, pwede ka na directly para mas wala nang paligoy-ligoy pa, di ba? So, directly kung anong problem ni patient. So, you have the background na, oh, that's very important, yung past past medical history, the medications, or the current na medical condition and the treatment, no? So, you have that history na before you go to the patient.
Murag sa ani doc nga example, murag specific na siya nga nag-probe on the reaction of
kasi you have that you have that background. Kaya mas na siya kasi limited kasi iba din ang setting when it comes sa CL psychiatry, you know that, di ba? Dili ka pwede makalingkod og kanang dugay, no? Worse if currently we have COVID situation that you can only interview the patient via phone. So there are so many restrictions, no, when it comes kung may medical or in pain pa si patient, no. That's why it's very important to read na and get kung ano yung mga pertinent doon sa chart ni patient, no, para mas madali. Okay?
Then it's also important to know about the patient's family and support. So we can use a genogram wherein we can convey the substantial clinical data, their family functioning, relevant family, medical, or psychiatric history as well. So we can include the extended family or significant other, and as well as the nature of relationships between them. So the patient's sense of these people's attitudes towards him, their knowledge about his current difficulties, and what they might think caused it could help, and it may shed light on the patient's own attitudes and his broader social identity. So a specific note regarding the availability of support from family and beyond and its quality is part of the inquiry. So we can opt to do this. So for example,
But
in
we're
this
not doing that. Medyo lisod na siya, no? But it's very important sa, siguro the support. Siguro
yes,
yon. And sino yung kailangan natin i-educate, no? When it comes kung papauwiin na natin yung patient or who's the current watcher of the patient, no? If the patient is suicidal, aggressive, no? But this one, kasi this parang article na binigay ko Nueva, it's more of kung ano talaga yung uh, dapat na susundin. So, but for us, no, that's very, Pero ano to, mga good to know. No?
baka
Sometimes we can
Dok,
apply.
may dinogram ako, Dok, sa chart.
Okay, sige.
Pero ano, Dok, in some cases, for example, the family is really not functioning. So as
Mm-mm.
CR, Doc, we can refer the patient to social worker. Ano.
As well as if may mga V-code diagnosis, 'di ba?
Mm.
Yung mga abuse, ganon, or that would be parang hindrance in the treatment, no, as a CL. So this is very helpful. Actually, depende sa cases, but this is good to know. Mm-mm.
So, so how do we understand these findings? So in the journal that was sent, it still uses the biopsychosocial approach. So so we can record how the biological processes in the patient that affects his current illness, his psychological, as well, not just his response to the current illness, or so we might include also other, I don't know if there are relevant trauma in the past, his pre-morbid personality, early family environment if it's relevant. So uh, you have to keep the CL notes short, but it also has to be complete. So, responses to illness pwede.
Uh,
Then,
Just want to point out lang sa psychological, no? Parang na-notice ko, parang yun yung always yung nakakalimutan natin, no? The responses of the patient. So, kasi that would be parang delineate us from the medical services or the surgical services kasi yun yung anong reactions ni patients, no? Tapos yung na-mention kanina ni Meva kung ano yung mga part of it na yung coping skills, reactions, no, behavioral, emotional, cognitive, no, that's very important kasi psychiatrist tayo, ito yung mga bagay na hindi nila alam na alam natin. Okay?
Also take it into context the sociocultural background. So like the education of the patient, poverty, and all the other quality of support and cultural identity and values as well. So, for example, we can state it as this. So, Mr. Smith has a history of vulnerability, both genetic and environmental. In addition to his father's alcohol abuse and mother's chronic anxiety, murag nag-psychodynamic, he describes both physical abuse and emotional neglect by the father and mother wholly important to intervene. So, he developed a view of himself as undeserving. So, he lost this main
Oo.
support.
No, sorry, Nueva. No, this is very ideal, no? So, I know na we have so many referrals. Hindi tayo pareho iba na parang isa-isa lang, di ba? Sometimes we get 4 referrals, no? So, it's really nice to know itong format nila. It's very ideal. But siguro, if kung you have time, no, at least isang referral na new, you can do this, no? That's very good practice for us, no? Kasi parang maganda siya kasi you really understand the patient from holistically. Di ba? This is, parang maganda siya. Pero yun lang, sa part natin that would be very, siya, Lisod kayo siya. Oo. Okay, sige. Ikaw may continue, Nueva.
Yes. It's ano lang daw, a good practice mo daw.
At least one, always, no, in a week, kahit isang referral na new, that you may do this, no, sa Viber group natin, no, that I appreciate that. But if not, siguro, I know naman na it's very difficult. Pero, yun lang, no? Parang kasi, we all, parang kung trainees tayo, no, we do our best to understand kung, or maximize our rotation.
So, and then of course, what do we recommend regarding the management? So, not always that our side notes will be read, but the most read would be our plans for the patient. So again, this should be congruent with and informed by the preceding sections that we have discussed. So we can have the statement again of the nature and degree of any risk of harm to self and or others, and how to address this, which is necessarily the first issue to highlight. And you can also state the need to mount further inquiries or to conduct special tests. And this should be discussed as well with the team or the consultee. Then treatment recommendations may cover psychotropic and other medications and psychological interventions as well, such as crisis counseling, couple therapy, brief dynamic therapy, and family therapy. Then systemic approaches may incorporate one or more staff meetings. So as if needed, we can conduct a team approach, team meeting for the patient. Then, so for that, clearly the psychiatrist here stated his plans, no, in a brief and direct manner. So he mentioned that although the patient wanted to be dead, it was more of a frustration rather than actual suicidal intent. Then, so he answered the question of the consultee here, and also his plans. So for example, adequate pain management, and the psychiatrist here mentioned also mag-meeting ang other specialists to really plan on the pain control of this patient, and stating it clearly that although that due to the findings, the antidepressants are not recommended at the time.
Okay. So, sa report ni Nueva, no, ito lang yung gusto ko sana na even though no, medyo dun sa part ng history natin, no, that hindi siya ganun ka-complete, but it should be lahat makukuha natin kung ano yung mga significant na parts of the history. But in the management, no, and the recommendations, no, sana we can do this na mas etong format na to, no? Kasi dun kasi sabi ni Nueva na ito yung parang binibigyan nila always ng pansin kung ano yung na ano natin, recommendations, no? At least, no? Kasi parang naano ko pa, for example, we always write supportive psychotherapy rendered. Hindi naman nila alam kung anong supportive psychotherapy. So you can write ano yung mga supportive therapy na ginawa ninyo. Like for example, psychoeducation to the patient and family. Ano yung sinpsychoeducate nyo? Tapos there is reassurance ba? No? Or ano pa yung mga other parts ng supportive psychotherapy na ginawa nyo? Or you did ba behavioral techniques to address the anxiety. So, pwede nyo yun isa-isahin. And then, most especially kasi, with the recommendations, at least, yung just point across natin kung ano yung gusto nating mangyari sa patient to be na understandable siya sa part ng nagbabasa, no? Especially with other services, as well as ma-understand din nila si patient. Kasi as CL psychiatrist, sometimes, di ba, tayo yung may more time with the patient. So, we are the advocate of the patient sometimes na hindi nila naiintindihan si patient. So, that would be our role. So, these recommendations regarding management, no? Please take note of this. Okay? At saka, I know sa atin kasi sa SPMC, no, hindi common yung mga pagpatawag ng multidisciplinary team meeting, no? Kasi very madami ang patients, no? Parang wala time na ang mga, maski nga like residents to residents, minsan hindi na natin yung nagagawa. No? But it's very important to talk about the patient and see kung ano yung parang management nila, findings, and recommendations. Sometimes kasi yung nakikita natin parang hindi siya nare-reflect din kung anong sinusulat nila. So if we like read lang doon sa notes, no, sometimes may miscommunication. Okay? And then we have to remember also when we write recommendations in a way na ano tayo, parang polite tayo if we inquire something and polite tayo if we suggest something, no? Or if, for example, parang may nakita tayo na medyo mali, may we inquire, ganon. So, in a way na parang hindi naman tayo bastos sa pagsulat sa sa chart, no? So, that's very important.
Ito. Then, this next part will just be, what further clinical developments have ensued. So this regards the follow-up consults already. So this section permits documentation of clinical developments which have taken place during the patient's admission. So, for example, what is the response of the patient to the current intervention, the change in the medical condition, acquisition of new data which sheds light on the original assessment, and possible factors to account for any deterioration in the mental state. Also can include the review of treatments such as medications or the need for a dedicated psychiatric nurse. So, para na sa mga follow-up na to.
Sorry, Nueva, I just nakalimutan ko lang. Want to emphasize with regards to the diagnosis. When we write the diagnosis, no, for CL, hindi siya strictly na dapat DSM-5. Okay? And we could write differential diagnosis from the most na nakukonsider natin to the list, no? So we could have like 1, 2, 3, no? And it's not really parang DSM-5. It's good kung may na findings tayo na like major depressive episode or major depressive disorder. Pero kung wala, like for example, parang reaction lang siya. So we could write na this behavior of the patient could be blah, 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 blah. So hindi siya strictly DSM-5 format. No? We could write na to the point na pwede siya na words na they can understand. Not necessarily yung mga diagnosis natin. So that is one of the differences when we write the diagnosis in CL notes. Okay? Kasi sometimes, di ba, wala namang parang, hindi naman nila na-fulfill yung DSM-5 criteria. Oo. So, yun.
Kung mga reaction niya lang, Dok, no?
Oo, we could write that. Oo.
Ito. So, it's just a documentation of the development.
Okay. We can, naman, skip that portion.
Yes, Dok. Then we can also recommend regarding psychosocial follow-up. So should have discharge recommendations and psychiatric follow-up needed to be recorded precisely to accomplish continuity of care and to prevent the patient slipping out of service loop. So if the patient needs to follow up at our institution, then we have to clearly state that. And a big suggestion that the patient would benefit from supportive therapy and monitoring of medication amplifies the risk of a dislocated follow-up. So we really have to specify asa siya magpa-schedule bar. Then we can also have, so this is an example, no? So in the case of Mr. Smith, the psychiatrist clearly stated that there should be coordinated pain management and that the GP should indicate a local pain program and a GP to work with Mr. Smith on building interests with the limits caused by the pain. So, pero mas polite lang siguro pagsulat mo. Okay. So, I think that's the end of my report.
Okay. Sorry, Nueva, di ba sa part dun sabi ni Keiko, meron dun yung process of CL.
Ay, kita daw.
Did you remember that? Mas maganda siya kung na-discuss in part of it. Kung ano yung process flow when we do CL. Para meron lang tayong overview of it.
Ay, wala na. Yung ano, Doc, step by step, Doc. Ay, kita, Doc.
Maybe you can like, discuss about it.
So these are the general steps in the consultation. So we can first review the chart and identify the consult question. And we can discuss this case with the consultee. So we can actually call the resident and ask what they really want from from the assessment. So, and then in our referrals, we always ask to indicate if it's a routine or urgent or emergent referral. Then during the patient interaction, we should introduce ourselves and sit down if there's space for us. Then
There's a chair.
Then we should share our reason for being there. So for example, sa ako I introduce no ako di ay si ayong buntag, ako di ay si Dr. Perucho. Gikan ako sa psychiatry, gi-refer ka sa imong resident para mag-assess ka na murag ana siya Doc.
Okay. Wait lang. Prior to that, meron na ba tayong parang informed consent?
Yes po, Doc. When they ask for po, Doc, may format ko, Doc, nga please send a picture of the interdepartmental referral, the patient's consent. Please clearly state the reason for referral, and if it's routine or Doc, emergency.
Okay. So that's very important, no, to ask for the informed consent, no, especially for us sa psychiatry. And yung awareness din ng patient, except na lang for the emergency cases, of course, no? Pero yun lang. Sometimes, no, di ba, patient, because of stigma, hindi din natin yung aalis minsan, may mga stigma. So, but we know, or the consultant knows, or us na parang it's very important na to have psychiatry on board. Sometimes you can, like, for example, sa introduce yourself, no? I'm, for example, Dr. Perucho, no? I'm part of the medical team that would assess blah, 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 this blah, 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 para parang hindi sila. But if the patient knew naman na she would be or he would be referred to psychiatry, pwede naman yung diretsyo na. But there are kasi parang special cases, no? That they hesitate to be referred. Okay? So that could be used na I'm part of the medical team, blah, 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 or diretsyo na I'm Dr. Perucho, part of the team that one. Kasi we want to assess you holistically. So part of it, mga psychological, ganito, ganyan. Okay?
Then also be mindful of the discomfort of the patient. So for example, patient is in pain or has difficulty in breathing, or inappropriate po nga magsigitag proceed sa interview na dili comfortable. Then perform a thorough interview and answer the patient's questions as able. But we have to be mindful of our role as psychiatrists. Kanang dili kita ang main ba. So for example, if it's pertaining to the illness, medical illness, we should veer away from explaining with regards to medical illness.
But if it's related, no, we could use that. No, na for example, kabalo ko na maragi na-admit ka because of a heart condition, no? Sometimes, no, there are responses na kailangan natin i-process sa'yo. So that's why we're referred to us to help you process that. So we could use sometimes that, no? Kasi syempre, most of these patients were admitted because of a medical reason. Then all of a sudden, bakit may psych? Okay?
Then after the history, we have to take the mental status exam. If it's indicated, we can do bedside cognitive testing and a targeted physical examination. And also ancillary history gathering, if appropriate, like the family, additional caregivers, is was kaning assessing the support of the patient. And step 4 is to write the written note. And next would be the verbal communication or feedback with the consultee regarding
That's very important, no? Na we have to at least inform the consultee kung ano yung findings natin and recommendations, no? Para at least may clarifications dun sa reason for the referral nila or na-address ba natin. Okay?
And then follow-up visits as appropriate. So, pero in RCL, kailangan man daily judok ang most patients. Then, kana na.
Okay. Sige. So, just you can stop share na. Ask, no? For example, si Sheng, ano yung na-realize mo with this presentation, no? With regards to your previous parang experience in psychiatry and in writing psychiatry notes, and also yung steps on how to conduct yung CL.
Hello Doc. Marinig po. Doc, isang realization ko po, Doc, yung importance talaga ng informed consent. Kasi merong times, Doc, na may mga stat referral, tapos yung IM usually. Then when I talk to the patient, ako yung itataboy. May ganun talaga. Then yung one time po, Doc, yung when I referred sa'yo, yung patient po na HIV patient na COVID positive, may informed consent naman, but when I talk to the mother and the patient, ayun pa din, ako pa din yung tinaboy ng family. Oo.
So what did you do during that time?
Ayun, yung sa case na yun, I talked to the main service na ganun yung yung reaction ng family na ayaw nilang magpa-refer po sa psychiatry for evaluation kasi yung medyo maselan, parang ayaw ng patient talaga na makipag-usap. So yun po.
So with those cases naman, hindi natin kailangan pilitin, no? If for example, naman sila, parang they have that mental capacity to refuse. Okay, hindi naman sila like super agitated na very emergency that we need to be on board, no? So for that, especially HIV, so very personal, no? So kailangan we have to respect the decision of the patient and the family. So but that's very important din na you have to write kung anong nangyari. Okay? So, isulat mo doon lahat kung anong nangyari para they can understand bakit ayaw ni patient. Okay? What else besides from that? However, how about doon sa composition ng CL notes? Ano yung parang kailangan mo i-improve or you realize after the discussion? Hello? Okay. Si Camille na lang. Baka nawala si Sheng. Okay.
Hi, Doc.
Sorry, Camille. Okay, sige. So, I know na natapos niyo na yung CL, but after this, ano pa yung further learnings mo when it comes or how you will improve if you will have like CL referral?
Maybe, Doc, more on putting into writing, Doc, ang kanang thoughts bitaw, Doc, in a more concise manner that the referring service would be able to understand po, Doc. And as well as nga dili kaayo ingon ana ka sabi na siya kanang maungkat bitaw tanan ang murag na pa ko'y matago for the patient, Doc, ba nga I know that the chart is there and everyone will see it from the nurses ana sa clerks, And sometimes naatay mga there are, for example, mga information that we also need to keep confidential. So as much as possible, lessen yung mga for example sa mga sexual na ano ng patient, doc. It would be better to be general, more general about it rather than specify how many sexual partners the patient has, ganun, or other promiscuous na mga activities. So that you will also keep parang the information confidential, but you parang ma-understand din ng referring service yung thoughts mo, why you have come up with the management and your recommendations, no? Parang ganun.
Oh, that's nice na realization, Camille, no? Actually, lahat yung di ba, very complete yung thorough yung report ni Nueva about it. But sometimes, no, especially the anamnesis part, the personal social part, sa atin na yun, no? That could be like, for example, isend nyo doon sa Viber group natin para ma-understand ko. But hindi lahat yun isusulat natin doon sa chart, no? Especially na very public, and not necessarily public, but sa lahat ng team, the medical, the nursing team, nababasa nila lahat yon. So, kailangan nyo na i-pick up kung ano yung mga dapat. Pero, does not keep you from asking. Okay? Sa atin na yon. Parang personal notes mo na yon. Okay? So, you need to know kung ano yung dapat pertinence lang na isusulat mo yun. So that's very important, kami yung realizations mo na yun. Hindi lahat, no? Especially the personal social, no? Yun yung natutunan ko dito na, like for example, when we do history taking, lahat-lahat from the referral, lahat yun tinitingnan natin on how Nueva, no, thorough. Pero when we write sa chart, pinipili na lang kung ano yung relevant doon sa case, ano yung pertinent na kailangan nilang malaman, especially the personal social history. Not as much. Pero when we endorse, no, when we write it sa data natin, we have to write it as kung ano yung dapat and thorough. Okay? How about you, Des? Sorry, yung seniors lang ha, para at least we know how to improve next time.
Good morning po, Doc. So, yung sa akin po, Doc, nag-realize ko sobrang kulang yung notes ko. Madami akong hindi na-include sa notes ko, Doc. Especially yung part ng response ng patient sa illness niya. Kasi kailangan din nating somehow ma-inform din yung consultee para mas maintindihan din nila yung pasyente bakit nagkakaganon. So yun yung pinaka nag-fail ako sa time na sa akin, Doc.
That's okay.
Parang hindi ko na liaise sa consultee para ma-understand nila kung bakit ganyan yung pasyente, nagkakaganyan yung pasyente niya. So, ganun po, Doc. Doon po ako And then, ano pa ba? So, yun, Doc, tapos yung sa psychological po na, yung like, paano yung mag-cope yung pasyente, medyo hindi ako nakapag-dig deeper yung sa time ko, Doc, na nag-history ako sa pasyente, nag-interview ako. Hindi ako nakapag-dig deeper dyan po, Doc. So, and then yung same po kami ng concern ni Doc Camps po, Doc, yung paano i-balance yung nalalaman ko sa ilalagay ko sa chart. So parang so medyo kaya natatagalan ako mag-notes kasi kailangan ko pa itong isulat, parang hindi naman, parang paano i-put into words na meron din silang makukuha at the same time meron maano pa din yung privacy ng pasyente. Meron pa, Doc.
Okay. Sige. That's why, no, I'm thinking now we could have, at least before bumalik si Doc Dova, we could have another didactics. I'm thinking about yung I think chapter 3 ba yun ni Levinson, yung psychological response to illness, no, that's one. And the other would be, I think, delirium. I need to discuss that with you. Kasi yun yung common natin na nakikita, no. So, siguro i-divide natin yun. Das would be Des and Sheng with the delirium, and this would be the psychological response. Siguro next week, can we do that? Saturday lang, sorry. Yun kasi yung yung free time. Okay? So, psychological, I think Levinson, chapter 3, no? Tama? Yung mga psychological response to illness. And then, the last would be yung delirium after ni Des. Okay? So, that would be okay sa inyo. No? Free naman yung seniors at juniors if they want to attend. Okay? Okay. Do you have other questions or concerns right now?
Naman, Doc. Thank you po.
Pero mag-istorya lang ko, Dok, katong hingon ni Des.
Yes, ano yan?
Yung psychological reaction, Dok, ba? Like, katong si patient na katong burn, Dok, ba? He was irritable, he was kanang murag, sa staff, sa medical management. Kaya ang psychological reaction niya pala doon sa pag-skin graft, Dok, ba? Na yung pagkuha pala ng skin doon sa thigh niya, yung sa psychological niya pala noon is like it's another scar, kumbaga. Murag sa inana nga kwan nga alias nimo to the consulting na inani siya tungod kay inani iyahang thinking.
Yeah,
Tapos ito nga ba.
Actually, that's a good case, no? Kasi parang doon mo nakikita yung denial, the anger, no? Doon mo siya ma-appreciate with that case, actually. And how you will, communicate that with other services, especially, di ba, with the nurses. Yun siya, di ba? Galit siya sa nurses and the other staff. Kasi parang they're not understanding his pain, his concerns, no? Okay. Alright. Sige. Meron pang other questions? Wala na. If none, you can leave na, but I'll talk to Nueva lang. Okay? Sige. So, yun lang, Des. We'll just, prepare for that on next Saturday. Okay?
Yes po, Doc.
Alright. Thank you, everyone.
Thank you po,
Doc.
Doc.
Sige. You may leave na. I'll just talk to Nueva. Ito, natulog siguro ito. Okay, mo na lang, Sheng, remove. Ay, Sheng, Nueva pala, sorry.